Hello class. In this presentation we're going to discuss clinical and rather diagnostic imaging approach to spinal arthropathies or arthritis. We'll start sort of looking at different categories of arthritis in the spine. We'll start with degenerative arthritis, rather degenerative disc disease. Pathologically, degenerative process of the spine in a very predictable, very consistent fashion initially affects the intervertebral disc and then later on progresses, since the weight-bearing and biomechanical forces tend to be accentuated on the posterior elements. Later on, degenerative disc disease progresses to spinal osteoarthritis, true spinal osteoarthritis that usually presents with facet joint degeneration, but also anchovertebral joint degeneration in the cervical spine. Now, radiographic imaging plays very crucial role, significant role at early and also subsequent diagnosis, but also monitoring of degenerative changes in the spine. MR imaging plays a significant role following the radiographic examination in order to actually demonstrate potential complications such as spinal canal stenosis, neuroforaminal narrowing, but also neurological abnormalities such as affecting the cord, perhaps suggesting myelopathy, and also radiculopathy affecting spinal nerve roots. Let's look at a nice diagram to indicate what do we consider as a spinal segment. So spinal segment usually considered as vertebral above, vertebral below, with the intervening intervertebral disc. That's considered as a spinal segment. So as you can see, degenerative process initially starts affecting the disc. Disc literally just dehydrates, and from weight-bearing processes, but any other kind of perhaps increased patient weight, but any other kind of phenomena that sometimes poorly understood is certain nutrition of the disc, certain kind of other factors, presence of glycosaminoglycans, even congenital or other genetic factors may affect it. But regardless, this is sort of inevitable gradual process that affects pretty much all humans. So typically you can see intervertebral disc, as we know, consists of nucleus pulposus, which is very kind of watery substance surrounded by dense ligamentous type tissue, dense sort of collagenous tissue known as annulus fibrosus. So gradually from sort of compressive sort of creep type changes, disc begins to dehydrate, and sometimes on imaging report on MRI you may see a term known as desiccation, a disc desiccation. That usually refers to some kind of loss of normal hydration in the disc that we observe, and we'll look at some of the examples. So you can see that sort of certain types of fissuring, rents may develop in the annulus, and on some occasions that disc, the rather nucleus pulposus, may potentially herniate through the annulus fibrosis. Gradually, it may be confined within the annulus, or actually lead to significant kind of degree of herniation and rather protrusion, exclusion, and sequestration. So we'll look at some of those examples. Other changes that you may see radiographically as we look at it, you may see some sort of changes in the vertebral disc, and also change of normal kind of curvature in the spine, such as change in lordosis, and maybe even sometimes exaggeration of cervical kyphosis or even lumbar kyphosis. So we'll look at it. Other changes that may potentially develop as thickening of ligamentum flavum, which may all contribute to spinal canal stenosis. In this case, you can see also facet proliferation or degeneration of facet arthrosis may also contribute to canal stenosis, and gradually kind of forming this sort of situation when neurological structures can be compromised. So let's look at radiographic imaging. In this case, you can see, where do you think spondylosis develops? By the way, the term spondylosis usually refers to degenerative process in the spine, and that can be either intervertebral disc degeneration, typically radiographically noted as narrowing the intervertebral disc height, and subsequently formation of osteophytes, more properly known as spondylophytes in the spine. Gradually you can see some sort of facet degeneration may develop as well. So this is your lateral radiographic view of the spine. In this case you can see the segments that are particularly more vulnerable and more significantly or commonly affecting is going to be C5, C6 and C7. So you can see disc space narrowing very readily observed. You can see some proliferation of vertebral end plate and formation of this rather spondylophytes. So spondylophytes can be anterior, rather marginal. If you go back here, you can see they can actually be within the circumference of the vertebral body. Okay, so in this case, you can see those spondylophytes can also be posterior. And when you get to cervical spine, that also contributes to spinal canal stenosis. And plate sclerosis is another significant feature of degenerative changes. Occasionally, we can see also calcification of the annulus as well. But in this case, because this segment is the most mobile, gradually like I said, spondylosis may affect that area more readily. In this case, you can see also change of normal alignment, reversal of normal lordosis, even focal kyphosis develop. In this sort of case, radiologists and hopefully clinicians, when you examine the radiograph, should be able to kind of determine whether you're observing sort of minor, mild, moderate, or severe type of spinal degenerative disease. Again, patient symptoms sometimes not very well correlated with this presentation. So on occasions we can observe these type of findings even without major signs and symptoms. On the other hand, some patients may present with most significant signs and symptoms, either localized to the neck or even referral without even significant sort of spinal radiographic changes. So again, occasionally it's not very well correlated. However, if the person presents with some significant localized pain as well as signs of radiculopathy or myelopathy, at this point you require to order an MRI. MRI will be most informative imaging modality in order to sort of diagnose and grade this disease, but also evaluate neurological structures. So in the cervical spine, remember there's also unconvertible joints. So uncinate processes, you can see, become sort of roughened, they can proliferate, they kind of sometimes protrude towards the neural foramina in here, the IVF, and then lead both to neural foraminal but also spinal canal stenosis. That's an additional feature, so you know it's a synovial joint, and then particularly degenerative changes will affect it. So in this case, you can see that's a normal appearance, radiographic appearance of the uncinate process at the unconvertible joint, but in this case you can see that sort of degenerative changes are readily demonstrated by on that image. So oblique views are very helpful sometimes to actually demonstrate that degree of narrowing of the intervertebral foramina. So in this case, you can see actually narrowing occurs both from posterior body osteophytes in this case and also uncinate process proliferation. So that narrowing can be correlated clinically with degree of potential radiculopathy, because nerve root, if you reduce the size of that foramina more than a third, more than 30%, so patients may potentially start developing symptoms. Once again, MRI will be more indicative if patient presents with neurological abnormalities. But if there are no neurological abnormalities, radiographic imaging can be sufficient and maybe sort of adequate for you to evaluate that process and provide a diagnosis. Now, it's also important if people involved in manipulative type of therapy, because that can actually kind of determine your level of care. Where sometimes if degenerative changes are relatively significant, manipulation might be contraindicated for multiple reasons, because of neurological complications, but also vascular complications, since we know some of those osteophytes in the area may also lead to compression of the vertebral arteries. So in the lumbar spine, you can see degenerative changes present with multiple features. We more readily see it in the lumbar spine, but other features, obviously you can see disc narrowing, relatively significant. You can also see, because disc dehydrates and loses water, then air pockets develop. And on X-ray we can see it as intradiscal vacuum, or basically intradiscal air. You can see that sort of streak or line of that gas, or rather air density in this case. You can also see spondylophyte formation, and because degeneration of the disc and degeneration of facets occurring, you might have situation of degenerative instability. In this case, it's going to be degenerative anterolaesthesis, but occasionally we can see degenerative retrolaesthesis. So typically when we look at instability of the spinal segments, then you usually refer proximal or superior vertebra in relation to the inferior vertebra, and in this case those lines outline the degree. By Meyer-Dean classification will help us to actually diagnose whether it's grade 1, 2, 3 or more degree of spondylolisthesis or anterolisthesis. But just as a clinical peril, most degenerative anterolisthesis, rather degenerative spondylolisthesis, rarely, if ever, progresses beyond grade 2, which is usually no more than 50% of basically vertebral body width, if you like. So in this case, you can see it's grade 1. You can see it sort of grade 1 because it's sort of 25% to a little bit more, maybe sort of borderline grade 1 to grade 2. But again, we usually report that in the report because that can contribute to spinal canal as well as neural foraminal stenosis. On the AP view, you can also see sometimes facet regularity quite well by roughening, some sort of proliferation of facets, and also sacroiliac joint arthrosis can be noted in this case. Sacroiliac joint arthrosis usually doesn't present major symptoms. Most of the symptoms that patients experience come from the lumbar spine, and most typical areas that are affected by lumbar disc disease and lumbar spondylosis are usually L4, L5, and S1. So that's where primarily most changes develop, and symptomatic in terms of nerve compression, chorioequina syndrome, or any other sort of types of radiculopathy observed, and any kind of neurological deficit observed in relation to spinal degenerative disc disease. So you can familiarize yourself with the Myerding classification, look for grading of anterolisthesis, or rather spondylolisthesis in the spine. Let's look at MR imaging. Like I said, MR imaging without gadolinium contrast is your modality of choice to demonstrate changes related to spondylosis, especially if they complicate by neurological manifestations. In this cervical MRI, you can see on T2, remember T2, CSF is bright. So in this case, you can see it's T2. All of these studies demonstrate different T2 slices. But in this case, you can see, in fact, you can see that significant loss of disc hydration and disc height. You can see proliferation of vertebra as spondylophytes or osteophytes. But in this case, also what you observe, there's a proliferation, or rather, thickening or sort of infolding of the ligamentum flavum, as well as for the protrusion of the disc with osteophytes, sometimes called as disc osteophyte complex. As you can see, that significantly leads to spinal canal stenosis. This can be also exaggerated by extension of the neck. So when you perform your neurological examination, it's very helpful as a clinical peril to actually sometimes examine those neurological signs, such as maybe clonus or any other kind of neuropathic signs, by putting that patient into extension. You may be able to demonstrate some changes. Now, a cord can be affected, and if that sort of condition progress, if these changes progress, it may lead to sometimes myelomalacia, or literally just sort of softening and some degenerative, if you like, reduction in normal neural tissue, and which may lead to with myelopathy, or rather compression of the spinal cord by degenerative changes. In this case, you can see multiple levels, and you can see degenerative disc disease, not significant complications. Cords is relatively well, can be not significant displays. However, on axial view, you can see there's a disc herniation, which is sort of focal. It kind of effaces or displaces part of the neural sac, or the thecal sac, but it doesn't cause significant pressure on the cord. Can it be symptomatic? Yes, because it can lead to local symptoms, but also on certain movement can also compress the actual nerve roots. Now, in the lumbar disease, it can actually see degenerative changes. So you can see in this case, right there, the hydration of the disc is a fluid-sensitive study. You can see CSF is nice and bright. That disc is well hydrated. However, at L4 and L5, you lose that normal hydration. That will be known as disc desiccation. Also, you can see some of those disc kind of protrusion and herniation of the disc, and also you can see that sort of high signal intensity within that protruded disc, also known as HIZ, or high intensity zone. That's another common thing that you will see reported at MRI by your radiologist. But in these cases, it's probably less complicated by severe sort of disc extrusion and sequestration, and probably not leading to significant neurological changes. But pain may still be present in those patients, and pain radiating along the nerve root can also be observed. However, probably less likely to leading to any kind of nerve compression and lower motor neuron signs. Now, just very briefly to familiarize you with the sort of nomenclature that you're going to read and going to come across of MRI report sent to you by radiologists. So normal disc typically represent that sort of, as you can see, annulus, and it's strictly confined by the ring apophysis. In other words, it corresponds to the end plates. Like in this case, you can see there's no degree of bulging. Now, gradually, as you lose that hydration, this kind of sags and it degenerates, and the fibers sort of becomes distorted, and literally you can see sometimes completely circumferential sort of extension of the disc beyond the ring apophysis, and that's known as a disc bulge, or you may see kind of that asymmetrical disc bulge. So on the report, the radiologist may report there's disc bulge, and that's what we refer to. And this nomenclature is very important because to avoid any confusion between bulge, protrusion, herniation, that's a consistent. So when a disc bulge, this is the kind of changes that are being observed in MRI. So we don't see any focal protrusion in the disc. Now, when you get that sort of protrusion, which is sort of less than 25% of that circumference, that's when typically disc protrusion, herniation will be reported. In this case, you can see it's still confined with a relatively broad base. It's still confined by the annulus fibrosis. So in this case, patient may experience symptoms. However, what we do not observe is actual extrusion or complete exiting or sort of bulging or prolapse rather of the annulus, of nucleus pulposus beyond the confinement of the annulus fibrosis. Now, extrusion of the disc will occur when the actual nucleus pulposus will completely escape beyond the confines of the annulus, and this process, so to speak, it's almost like you squeeze the toothpaste out of the container, and then you cannot push it back. So in this case, it's kind of just the neck, or rather the base of that protrusion, herniation, it's much narrower than the actual herniation itself. And on occasions, you can see that it's completely sequestered. In other words, it's separated from the annulus. And, in the favorable cases, and, if the patient is lucky, it can kind of fall down the canal and just dehydrate and just disappear. But on some occasions, it can kind of, significantly extend posterior longitudinal ligament, or even compress in the neurological structures, leading to some significant complications where surgery may be required. So basically, in these cases of just the bulge and the protrusion, rarely surgery is required. However, if you see some sort of extrusion and sequestration, if there's a significant, like in this case, is going to be central, in most cases, it's going to be paracentral, or kind of like posterolateral, but sometimes during central, canal can be narrowed and chorda equina can develop. So in all cases of severe neurological complication, that's when the surgery is indicated. But really, in other cases, conservative care can be effectively performed. For extra information, please refer to this excellent article about degenerative disc disease. So other degenerative processes that affect the spine is known as DISH, or diffuse idiopathic skeletal hyperostosis. Now, this is not typically related to degenerative disc disease. In fact, what we observe, presence of DISH usually presents radiographically with lack of degenerative, or rather disc narrowing, or lack of osteophytes. But what it actually pathologically is, it's gradual ossification of the anterior longitudinal ligament, and that's known as DISH, also known as diffuse idiopathic skeletal hyperostosis, or Forestier disease. And most commonly, it actually affects thoracic spine, kind of, mid to lower thoracic spine. But second most common site is going to be cervical region. And typically it presents, as you can see here, sort of that flowing ossification of the anterior longitudinal ligament, which typically going to be more anterior to the actual vertebral body, basically margin, and that's what helps to differentiate it from sort of degenerative osteophyte formation, etc., etc. Now, DISH in itself is just a radiographic diagnosis. In most cases, patients will not experience any symptoms and probably discovered just by radiography. Now, occasionally it can actually present with complications because it forms like a rigid spine disease complication. So if the person's ability of the neck to dissipate sources, sort of mechanical forces, tend to be reduced, and then any kind of isolation, deceleration injury, or some kind of significant forces acting on the spine may actually lead to fracture, and the fracture can occur in a very complicated way known as a chalk stick or carrot stick fracture. Typically, the fracture will affect sort of most tightly attached part of the disc, part of the dish, basically that ossification of the ligament most tightly attached to the vertebral body, and typically may affect sort of the end plate, but also affect posterior elements. So it kind of like goes across all three spinal columns, leading to potential significant instability. In this case, you can see the CT scanning was required. In this case, you can see that area of fracture, and it's sort of extending posteriorly in this case, leading to severe instability. Now, in this patient, in fact, you see both dish, but also ossification of posterior longitudinal ligament, known as OPLL, that we'll talk about it next. So OPLL, in fact, it's less common than dish. Dish is very common. The other thing I just wanted to mention, that dish is also associated, significant dish, especially when we see it in extraspinal site like pelvis, is associated with type 2 diabetes. Close to 49% of patients often have type 2 diabetes. But again, you may find it without any diabetes in some patients, especially in the spine. It's a relatively common condition. However, OPLL, ossification of posterior longitudinal ligament, like you observe here, it's much less frequent. However, it can lead to more complications because it narrows, it turns into a complete ossified structure, and it can actually narrow, significantly narrow spinal canal, leading to spinal stenosis and myelopathy. And this condition, in fact, is a little bit more frequent in Asian population, particularly in Japan, and some of those techniques that of treating this condition were pioneered in that part of the world. And sometimes it's even used here to treat some, degenerative disc disease and spondylosis, and that's known as laminoplasty. So instead of performing complete fusion of the spine, you may actually remove parts of the lamina and then, lead to basically bridging titanium plate to increase the size and the dimension of the spinal canal, and sort of reducing any potential neurological symptoms. So you can see OPLL, ossification of posterior longitudinal ligament. So this one can be more symptomatic. So typically on X-ray, you can see it as sort of that line, continuous radio-dense, radio-opaque line located posterior to the vertebral body. In fact, this person has both OPLL, but also you can see some formation of the dish as well. Inflammatory arthritis affecting the spine. So among all the inflammatory conditions affecting the spine, the most common and most severe is going to be rheumatoid arthritis. In fact, close to 75 or even 80% or even more, depending on the source, between 70 and 90% of patients with rheumatoid arthritis will also have some changes affecting their spine. So cervical spine is the most common site, and especially the area of C1 and C2. So basically we know that rheumatoid arthritis, it's an inflammatory disease affecting synovial tissue. So between C1 and C2 you have multiple synovial sites, synovial membrane. So that sort of proliferation and pannus formation and that inflammatory proliferation of synovium can lead both, initially sort of, it kind of enlarges, can compress the cord, but also destroy your ligaments, leading to significant instability of C1, C2, and potential neurological complications. So remember, any kind of high velocity manipulations are strictly contraindicated to this patient. Now, the other thing you can see also gradually is potential erosion and changes affecting the actual odontoid process. And then multiple instability can develop. It can develop in the sagittal way, so that sort of anterior and posterior instability, but also, it can sort of destroy the connective tissue of the ligaments that hold, like your C1, C2, and it can sort of migrate sort of, towards cephalate migration. So that's also known as cranial settling, which can sometimes compress spinal cord and lead to neurological complications. In fact, neurological complications are relatively common. However, they're not often life-threatening. So in very, very few rare cases, almost case report probably were described when patients with significant, RA affecting C1, C2 in that area may result with significant cord compression and death. In most cases, usually there are some sort of local signs, headaches, neck pain, and probably some neurological signs, but usually they are more manageable. But again, in severe cases, surgery will be required. So let's look at some of those imaging. So X-ray can be quite helpful, and typically what you observe, even in a neutral position, you can see that sort of widening of the ADI, more than 5 millimeters in adult, will be very suspicious for instability. Other things such as, sort of cranial settling can also be observed by multiple things, because you can see that anterior arch may appear a little bit lower where it should be. So in this case, there's a mild cranial settling occurred, but typically most significantly noted as increase in anterior atlantodental interspace and posterior atlantodental interspace, which on movement will also change. So you can see that on flexion is a significant increase, on extension there'll be significant decrease of the anterior atlantodental interspace, indicating instability. So in this patient with RA, even without seeing any changes in the subaxial cervical spine, you can see some significant, rather in the lower cervical spine, you can see some significant erosive change in the odontoid process, and also degree of instability or laxity and destruction of the connective tissue, or some of those transverse ligament of the dens and cruciform ligament, and obviously leading to what we call subluxation. And basically destruction and instability, subluxation, even dislocation. In this case, you can see other changes in the spine. You can see some changes between C1 and C2, basically instability of the C1, C2, subluxation in C1, C2, but also other. So RA, it's a synovial disease, so it affects facet joints more severely, and it can lead to destruction of facets and also instability, often known as step ladder deformity. So what kind of imaging do you require? You can start with X-rays, and you should definitely follow with MR imaging to evaluate for any potential cord compression, for any kind of neurological type of abnormalities. In this case, MRI can indicate few. You can see that sort of proliferation, high signal intensity, that basically shows that pannus formation, or that proliferation of tissue of the synovium at C1, C2. In itself, it can lead to cord compression, but more importantly, it can also destroy connective tissue, leading to multiple form of instability, whereby even a minor trauma or no trauma lead to sometimes serious complications. And you can see some changes in the subaxial spine, but they sort of indicate some disc disease as well. But most changes obviously are observed right there at C1, C2. Physically, patient may report some of the tingling and pain and sort of electric shock sensation traveling down the spine, known as Lermit's phenomenon, and also any other signs of myelopathy that you should be familiar, such as upper motor neuron lesion affecting, if you like, your long tracts, and perhaps other kind of neurological sequelae as well. So operative care is important in some of these very unstable cases. You can see some MR imaging showing significant pannus formation, destruction, cord compression. You can see some instability, some of that step ladder deformity affecting lower cervical spine, and in this case, complete cervical fusion. Posterior cervical fusion, in fact, with the occiput was performed to avoid some serious complications in this patient. So a few words about seronegative spondyloarthropathies. So there's another type of inflammatory type of arthropathy affecting the spine. And when you consider there are multiple of them, so seronegative, what it actually means is basically lack of rheumatoid factor. So with rheumatoid arthritis, most patients have rheumatoid factor present, and also anticyclic citrulline peptide antibodies, which is kind of more confirmative, rather more indicative of rheumatoid arthritis itself. But in patients with seronegative spondyloarthropathy, you will have absence of rheumatoid factor. However, in most of these patients, close to 90% of them, you'll have the presence of HLA-B27, which is human leukocyte antigen type of sort of epitope, and some of those antigen presenting cell, which is highly present in those patients who develop this type of arthropathy. So what type of arthropathy is there? So the most common is going to be ankylosing spondylitis. The condition, which is very similar radiographically to ankylosing spondylitis, is going to be enteropathic arthritis, and typically develop in kind of more advanced or complicated cases of Crohn's disease and ulcerative colitis, or inflammatory bowel disease. Other conditions with lesser frequency, but once again, is something between 20 and 60% of patients with psoriatic arthritis, which is typically affect fingers and toes, may also present with some sort of spinal changes. And reactive arthritis, formerly known as Writer's syndrome. It's sort of like a transient type condition affecting some kind of inflammatory infectious process, whereby later on can present with reactive type arthritis affecting peripheral joints, especially distal extremity, and potentially spine or sacroiliac area. So let's look at we'll start with ankylosing spondylitis. Ankylosing spondylitis is a kind of gradual progressive disease, and it's a nice picture to show you that this individual is much more common in men, over significant number of patients, close to, I think the ratio is sometimes reported as 8-to-1 or 12-to-1, men and women. But again, it can develop in women, but more readily develop in men. Clinically, they present as sort of back pain in young individuals. So the average age of onset, you look at patients in their 20s and 30s. After the age of 40, AS in itself, again, you may have other form of arthritis, like perhaps enteropathic arthritis, but otherwise, ankylosing spondylitis developing as a primary condition, it's much less frequent in men over 40s and 50s. So the typical age of onset is going to be young men. And in this case, you can see it was young men in, 1947, and disease gradually progresses. And then sort of, literally decades later, it sort of progressed to very debilitating type disease. Unfortunately, that's the case with ankylosing spondylitis. Sometimes treatment can be difficult as well. So let's look at most important radiological features. Now remember, clinically, ankylosing spondylitis presents with back pain. And back pain is maybe sometimes not very dramatic. So that ongoing back pain that may be considered as even mechanical back pain, because the person is young, active, and people sometimes sort of, think about it as a just mechanical back pain. Maybe may treat them for a while. And in fact, literature shows that the majority of patients with ankylosing spondylitis diagnosed sometimes 9 months or even longer after the onset of their symptoms. Once again, because the symptoms sometimes ignored by patients and ignored by physicians themselves. But in all cases, again, likely in 100% of cases of ankylosing spondylitis, it starts with sacroiliitis. In other words, it's enthesitis or inflammation affecting insertion of ligament, tendon into the actual bone. And typically it presents with perhaps, some sort of incongruity or erosion or irregularity. So usually you can see there's a different type of classification for severity of sacroiliitis, but typically you see sometimes lack of distinctness, some kind of blurring, loss of normal white cortical margin of the bone. And occasionally you may see even a little bit of pseudo widening. So most changes affect the subchondral bone of the iliac side of the articulations most commonly. And in AS cases, the sacroiliitis is usually bilateral and symmetrical, affecting both joints equally. So you can see gradually that erosion kind of occurs more readily. It's sort of, that's the sort of diagnosis you should be looking for if you note these type of changes. So remember, sacroiliac joints can look sometimes different in all people, but what you're looking for, you need to have a nice, wide, continuous, pencil sort of thin cortical line. If they start losing that cortical line, sort of it's distorted, blurred, smudged in this case, so in this case you should be suspecting sacroiliitis, and patient requires blood test. And the blood test that you need to order, usually HLA-B27, C-reactive protein, and basically you can look for signs of inflammation, but also high presence of HLA-B27. MR imaging sometimes can be also indicated, but again, in most cases, starts with sacroiliitis, progresses with its severity sometimes over the period of time, and then progresses to complete joint ankylosis. Now, with ankylosing spondylitis, usually starts as sacroiliitis and then works its way up to the spine. It will never affect the spine initially and then affect sacroiliac joints. In the majority of cases, it starts with sacroiliitis and then progresses, work its way up. So you can see kind of sacroiliitis can be seen on X-ray as sort of, that indistinctness, erosion, sometimes known as rosary bead, or some kind of erosive changes, and subchondral sclerosis, kind of reactive production of subchondral bone due to fibroblasts and activation of osteoblasts. So you can see that sort of reactive changes. Also, sacral side will also be affected, but usually subchondral on the iliac side, that side is affected more readily, early, and more severely. Again, you can also see, sometimes, basically CT scanning may help you to diagnosis. But in this case, this joint is probably looking normal because the cortex is nice and smooth. In this case, the cortex is nice and smooth. Maybe, somewhat sort of a little bit blurred and disturbed here. But again, normal sacroiliac joints can be seen by this nice crisp white cortical line versus blurring, indistinctness, and erosion presented with sacroiliitis. And again, MR imaging is most helpful in order to demonstrate it. So in the spine, it presents with some of those changes affecting, again, junction of the disc and the vertebral end plate. And again, it's something known as discovertebral osteitis. Now, on X-ray, it's known as Romanus lesion and shiny corner because it can demonstrate with erosion, but also sclerosis and then gradual formation of this entity. And again, it's continuous without any skip areas. And this known as marginal syndesmophyte. So marginal syndesmophyte is the key that you find in ankylosing spondylitis, and that's what helps to differentiate it between ankylosing spondylitis or any other form of spondyloarthropathy such as psoriatic arthritis or iritis or reactive arthritis. Now, marginal syndesmophyte also can be seen in enteropathic arthritis because enteropathic arthritis is virtually indistinguishable from ankylosing spondylitis on imaging. However, enteropathic arthritis tend to affect the spine a little bit less severely than AS. But again, can affect sacroiliitis. So gradual process, as you can see on MRI, you can see that sort of corner sign, that sort of appearance of high signal intensity on both in T1 and T2, because this is T1 imaging. And the reason for that there's some ongoing inflammation, as you can see here, high signal intensity is T2, but it's also high signal intensity on T1. And the reason for that, because there's a fatty type degeneration of normal marrow, post-inflammatory, and then bridging syndesmophyte and marginal syndesmophyte will occur. Gradually, they're going to ossify, lead to this bamboo spine and ossification of all spinal ligaments, noted as Torrey tract appearance, ossification of the capsular ligaments, and the dagger sign, or ossification of interspinous and supraspinous ligaments, with complete ankylosis. In the spine, in the C-spine, you can also see the same sort of findings. And that's when you naturally identify how, changes can affect and completely fuse that spine. Now, occasionally destruction of the disc and basically inflammation, as you can see here, may also be called as Anderson lesion. That's been known in the literature. So in this advanced case, other joints, peripheral joints, AS tend to spare your distal joints, but it affects root joints. So typically root joints refer as hips, affecting bilaterally, and shoulders. So in this case, you can see inflammatory pattern of arthritis with axial migration in the hip, a little bit of erosive changes, and in this case, advanced case, shows your complete ankylosis of the sacroiliac joint, hip joints, but also in the spine. That's advanced case of AS. Now, complications, apart from local complications such as canal stenosis, duralactasia, and multiple other complications, another significant complication, because that increases the chances of fracture in the spine. And the fracture, because there's a rigid disease, spine is unable to dissipate forces, it's very inflexible, and this way you can have a complete fracture through all three columns, complete kind of like a snap fracture of the vertebral column, and that's known as carrot stick or chalk stick fracture. In the cervical spine, it can be devastating. You can see some significant cord compression led to kind of complete fusion in the spine. Again, differentiation of non-marginal syndesmophyte. So basically, they're different from marginal syndesmophyte that bridge end plate to end plate, anteriorly and posteriorly, as well as laterally. Now, non-marginal syndesmophyte, they come distance away from the end plate. They can be relatively bulky. Sometimes they're known as bulky paravertebral ossification. And this will be the feature of psoriatic arthritis or reactive arthritis or Reisen syndrome. And that's what we need to appreciate. We need to remember that. That's the feature for radiographically that helps you to differentiate between AS and non-AS or other seronegative arthropathy, such as reactive arthritis and psoriatic arthropathy. For more information, please refer for clinical detail to some excellent article which I attach here. And thank you very much.